Welcome to the abdominal exam. The first part of the abdominal exam or any exam is to introduce yourself to the patient. Hi,
Hi.
I'm Amanda DeVos. I'm going to be the PA doing your abdominal exam. The next part you want to do is make sure that your patient is lying comfortably supine on the table. I'm going to have you lay back and I'm going to pull out this leg rest for your legs, making sure that you clean your hands before you do the exam. Second part of the exam is to make sure that the abdomen is adequately exposed, making sure that you use your gown and both your drape sheet. I'm going to put this sheet over your legs, and then I'm going to then pull up your gown. Gown should be up to about mid-chest. Sheet often easiest is if you tuck it into the pant line and have it at the iliac crest to expose all of the abdomen. The first part of any exam is to inspect. I'm going to be looking at his abdomen, looking for any skin characteristics such as any scars, any hernias, or any masses that I can see. I'm going to be looking for venous return pattern when patients have complications with cardiac disease, liver disease, or portal systemic problems. They often have problems with blood getting back to their heart, and they have enlargement or engorgement of their abdominal veins. Many times these are surface veins that you can see actually on the skin of the abdomen. The next thing that I'll look for is contour, noting if the abdomen is flat, if it is scaphoid, or if it was distended or greatly distended with fluid. Next, looking for symmetry and making sure that both of the abdomen look symmetric, paying attention to the flanks and noting if there's any bulging of any flanks or if there is any scars, hernias, or such in the abdomen. I'm next going to look for surface motion, so just looking for any motion with the abdomen. Oftentimes you will see motion with breathing. You may also see some pulsations related to the abdominal aorta. This can be normal to see, but you're looking for any abnormal pulsations outside of the abdominal aorta. Last part of inspection is to have the patient lift their head off the bed, looking at the midline and the umbilicus area, looking for any hernias or masses in that area. Have you put your head back down. Next, I'm going to auscultate. I'm first going to listen with the diaphragm of my stethoscope. I'm going to listen to all four quadrants, listening for bowel sounds. Usually it only takes a few seconds to hear bowel sounds, of which you can then move to the next quadrant. Sometimes you have to listen longer, sometimes 30 seconds up to 1 or 2 minutes. You're listening for, again, any bowel sounds, hypoactive, hyperactive, or absent. Next, with the diaphragm, I'm also going to listen for friction rubs both over the liver and the spleen. These can be heard sometimes if patients have infections, masses, or tumors in those areas. Again, a friction rub will sound like if you rub your fingers together and put it by your ear, that is exactly what you're listening. I'm going to listen for that both over the liver and also over the spleen. Now with auscultation, I'm going to listen with the bell portion. I'm going to listen for his arteries within his abdomen. I'm going to first start with the aortic artery, then moving just a few centimeters down from that on either side of the umbilicus, listening for the renal arteries, the iliac arteries, and lastly the femoral arteries. Oftentimes for the femoral arteries, it's easiest to palpate those arteries first and then slip your stethoscope in to listen to them. This is for the aorta. And then moving a few centimeters down for the renals. Listening at the iliac arteries. And then palpating for the femorals. Good. And then palpating on the right side. Next, I'm going to percuss or tap in the abdomen. I'm going to start by percussing for tone in all 4 quadrants and listening for any change in percussion sounds throughout the 4 quadrants. Oftentimes in the left upper quadrant, you can percuss the gastric bubble, and the tympani will be much higher in that portion. Next, I'm going to percuss both the liver and the spleen. For the liver portion, you'll want to percuss in the midclavicular line, starting inferiorly and moving superiorly. Once you hear a change in the percussion sound, that's going to be the inferior border of the liver, and you're going to stop, and then you're going to percuss for the superior margin of the liver. So I'll start with the inferior border first. So here's the first sound difference that I hear. Again, I started in the midclavicular line. I started about at the area of the umbilicus and moved superiorly. Now I'm going to palpate for the, or percuss for the superior edge, starting above where I think it's going to be. And then I've heard a difference there. I would take these 2 areas that I had, and I could use a measurement card and measure for centimeters in that area. Oftentimes 8 to 10 centimeters is considered normal for the liver span. For the liver, you want to make sure that you are exactly doing this in the midclavicular line. If you get too medially or laterally, the different lobes of the liver are larger than each other, and your measurements may be off. For percussion of the spleen generally is not palpable or percussible. But when a spleen does enlarge, it enlarges both inferiorly, so moves down, and also medially, or more towards the center. With that, you'll be able to percuss the spleen earlier than you would in somebody who has a normal size spleen. So start around midclavicular line and going laterally in the area where the spleen would be. Again, listening for any dullness. It should be normal to hear the dullness only in the mid-axillary line. Again, an abnormality would be hearing the splenic dullness more medially at that point. For both the liver and the spleen, any abnormalities that you may hear with percussion, you will further investigate with palpation of the abdomen. Next, I'm going to lightly palpate the abdomen. Couple important tips to remember for palpation of the abdomen. One is to have the patient bring their knees up and rest. This helps to reduce any muscular tension within the abdomen. Next, you want to make sure that you're always watching the patient's face while you're palpating the abdomen. Oftentimes, people's facial expressions may let you know if there's any tenderness. Lastly, for palpation of the abdomen, if the patient has any specific pain areas, you want to palpate furthest away from those, moving then towards the area of pain. This allows for exploration of the non-painful areas before you move into any tender areas. So I'm going to palpate your abdomen first lightly, and just let me know if there's any pain or tenderness with this. So I'm going to palpate for muscular resistance and for any guarding, just lightly moving throughout the abdomen. Noting if there's any masses or tenderness with this. Next, I'm going to palpate a little bit deeper. You can do this with one hand, just pressing deeper into the abdomen, or you can do it with 2 hands. Again, making sure that you watch the patient and monitoring them for any signs of discomfort. I'm going to pay special attention to the umbilicus or the umbilical area, palpating for any masses or hernias in that ring. I'm going to palpate for the liver edge. For this, there's 2 techniques that you can do. One is called the hooking technique, in which you hook your fingers around the patient's rib cage like this. And then to perform this test, you'll ask the patient to take a deep breath in. When they inhale, you'll be able to feel that liver edge move against your hands. So have you take a deep breath in and out. The second technique that you can do is you can place your hand right here in the right upper quadrant, and again have the patient take the deep breath in and blow it out. Again, feeling for that liver edge or that liver margin to move across your fingers. You'll also want to palpate for a spleen tip. Again, putting your hand right in the left upper quadrant, having you take a deep breath in and blow it out. Again, noting that it is normal not to palpate the spleen. Next, I'm going to palpate both your right and left kidneys. For this technique, you're going to place one hand underneath the patient, the other hand on top of the abdomen, and try to compress the kidneys between your hands. Oftentimes, if you're going to feel a kidney, it's going to be on the right side rather than the left side. Also, patient size and abdominal cavity really determines whether or not you can feel a kidney. Similar to the spleen, it's often normal not to palpate kidneys. That concludes the palpation portion. Again, with deep palpation, you want to make sure that you're feeling for any masses in that area. For the next portion of the exam, I'm going to have you sit up. And I'm just going to have you swing your legs over to the side here for demonstration purposes. I'm going to do some percussion of your back, or kind of tapping your back to see if there's any pain. This is for costovertebral angle tenderness, or in patients who have kidney pain or kidney problems. So I'm just going to tap your back. Please let me know if there's any pain with this. Any pain? No. The last portion of a complete abdominal exam would be to perform a digital rectal exam. We won't be doing that today or discussing that, but it is something that should be stated as part of the abdominal exam. So the last part of the exam, I'll run through some of the special tests that can be done depending on what you find on your initial exam. The first tests that we'll do have to do with a patient with a distended abdomen, of which you are considering that they have ascites or fluid within their abdomen. Again, a patient with ascites oftentimes will have a significantly distended abdomen, and we're seeing if we can palpate or feel that there's any fluid within that abdomen. The first test that we'll do is a test for the fluid wave. You'll need to have the patient participation or somebody else help you with this. So what I'll ask you to do is to take your hands and kind of make a line right down the middle of your abdomen for you, and just put a little bit of pressure on your belly. What this does is if there's fluid within the belly, I'm going to tap on one side of the abdomen and sense for the wave or the feeling of the fluid coming to the other side. What the patient is doing is putting some pressure on any abdominal fat that would be there and stopping the wave from moving through the abdominal fat. So again, having the patient push down, one hand is placed on one side of the abdomen, the other hand on the other side, and you simply push to get the wave of fluid to move. Okay? The second special test that you can do for ascites is something called shifting dullness. When a patient lies supine, the fluid in their belly should go to the flanks first and lastly come up to the top. So I'm going to do some percussion to see if you could hear the difference if a patient had ascites. For this, you would start at the top and move down to the flanks. Now this patient does not have any ascites or fluid in his abdomen, so again, it's hard to hear. You would note as to when you heard the difference of the sound and when the fluid became more dull. It's called shifting because you will try to get this fluid to move. Say in this patient his abdomen was distended, I percussed to a certain point, and this is where I heard the sound change. At this point, I would ask the patient to turn over on their side, so I'll have you turn onto your left side. Have them rest here for a little bit, and what that's going to do is any fluid that was on this flank is now going to move down to this area. So I would do that percussion again, but with shifting dullness, you would expect that you would hear that change in percussion to happen a little bit sooner. So again, starting on one side and percussing until you hear that change. Again, with shifting dullness, as the fluid is now all on his left side, the fluid wave and fluid line should move up. I can have you lay back. The next special test would be for a patient who has a gallbladder issue or cholecystitis. This is palpation of the gallbladder, and what you do for this test, called Murphy's test, is it's like you're percussing or like you're palpating the liver. And what I'll talk you through this first, and then I'll have you do the exam. So a positive test would be when you palpate in the right upper quadrant, have the patient take a deep breath in, and they will stop breathing because of the pain halfway during the inspiration. That is because, again, the diaphragm is pushing down on the liver and thus the gallbladder, and the inflamed gallbladder is coming into contact with your hand, thus causing extreme discomfort for the patient. So you have your hand in the right upper quadrant, have the patient take a deep breath in, and if they were to stop or gasp during inspiration, that would be a positive Murphy's sign. Good. Another test that you can do is called ballottement. A ballottement is feeling of a mass that is within a cavity of fluid. So if a patient has considerable amount of ascites or blood within their abdomen, you need to push at almost a 90-degree angle to ballot or palpate that organ or mass. This is done, again, by almost 90-degree angle palpation of the mass, of where you push down into the abdomen to displace or move the fluid or blood away so that you can actually palpate the organ. The last three special exams that we have to do with patients with peritonitis, often with inflamed gallbladder. One of those is called rebound tenderness. In this test, you simply ask the patient if the pain is worse when you push in or when you let go. When you let go, you'll let go rather quickly. In a patient who has peritonitis or an inflamed peritoneal cavity, the rebound or the letting go will cause a wave of discomfort through their abdomen. So again, just pushing down, is your pain worse with pushing in or when I let go? If it happens when I let go, that is a positive rebound tenderness. The next test that you can do for appendicitis is called the iliopsoas sign. Often the iliopsoas muscle gets inflamed because of where the appendix is located. In this test, you simply place your hand on the patient's right leg, just above his knee, and I'm just going to ask you to try to lift your leg with my hand here. Because of the inflammation of the iliopsoas muscle, this causes extreme pain in these patients. I can have you put that down. It is also good to make sure that you're checking both sides in this patient. In a patient that you would suspect appendicitis, you may want to do this on the left side first to see if that elicits pain, and then onto the more painful side of the right side. The last test is the obturator muscle test. So the obturator muscle also can become irritated and inflamed in a patient with appendicitis. For this test, I would have the patient flex their hip. So I'm just going to have you bend your knee, and then you're going to just internally and externally rotate that hip. Again, they will have pain with internal rotation of the hip if they have inflammation of the obturator muscle. So that concludes the abdominal exam, including the special tests.